Thank you, Jermaine. All right, if you have stragglers, just show them the PowerPoint that you have already pulled up for yourself. All right, so my name is April Oury. Bob and I work together, and we have had so much fun together for the last couple of years because we do come at treatment from a different philosophy, but we figured out how to put it together. And so the fun part for us today is showing you one, then the other, and then eventually, just like we do in the clinic, hey, Bob, I'm kind of stuck with this patient. What do you think? Well, have you talked about that yet? No, I haven't even looked at that. Hey, April, you know what? I was doing really great with this patient. Just want your eyes on this. I mean, we say that literally every single day, all day long with one another as therapists. So we wanted to bring that to you today. So my background is definitely more Institute of Physical Art, functional manual therapy background. I also teach with them and have been doing so since I think 2000. And just a fantastic organization. Founders are Greg and Vicki Johnson. They're also very good friends of mine. They're also mentors of mine, as defined by these two sitting up front yesterday at the mentor presentation. If you missed it, I strongly recommend you get the download online. It was really a great presentation. And they really fit that for me because a mentor isn't just somebody who teaches you things, but they help you out with a number of different aspects of life. And so Greg and Vicki have been very instrumental in my personal growth as well as my professional growth. So I have a great deal of respect for them. They started out in 1978, after I was born as well. And they had a very strong neuro background. So they were actually at the Kaiser Vallejo program, working with mostly neuro patients. And understanding that function, before function was a big buzzword in the insurance industry and the personal trainers now in the fitness industry and PT, that it was all about, can the patient get themselves from the toilet to their wheelchair? That was function at that point. And so what they were looking at is, how does the muscle fire, how can I get them to activate, and can this person do that themselves, and how much assistance do they need, right? And what they were getting frustrated with is, at some point, they've got the patient on the toilet, and they're like, okay, we've done that part, OT has helped out with what they're doing while they're there, now we need to go to the next level of movements, okay, we're going to transfer. And the patient didn't have some sort of X that they couldn't figure out what it was. And then they started realizing that their manual therapy background, because they also were very involved with a lot of they call them body workers at that time. We don't really call people body workers anymore, but the massage therapists, the Rolfers, anybody who's working on the repairs, more of the joint mobilization ideas, and going, okay, well, we're treating these neuro patients, but if their knee can't bend to get it underneath them as a base of support, it doesn't matter how great their muscles are, they can't get from the toilet to the wheelchair. And started then treating their neuro cases more like orthopedic cases, and started doing more manual therapy for these patients and getting pretty phenomenal results. So they ended up founding the Institute of Physical Art and marrying a lot of the manual therapy with what was called neuromuscular, not really motor control at that point, but more neuromuscular pieces together, and coming up with all the different courses that they have. I think they've got maybe 15 or so classes at the moment, I believe 6 of which you take in order to become certified as one of the functional manual therapists. So their big thing, as is everyone's, enhancing optimal movement and human function. So what are the different pillars or the operational definitions? So if we look at the IPA or a functional manual therapist, that therapist is coming to a patient with 3 different pillars. We've got mechanical, neuromuscular, and motor control. And there really is a big difference between neuromuscular and motor control, which we'll get to in a moment. So the mechanical piece of this is defined by, not is there a restriction, but can that body physically, passively get into appropriate alignment for that task? Can we'll talk about hip, can the hip sit in the acetabulum without being sheared forward, backwards, out to the side, and too much abduction, too much adduction for its task? Can it passively assume a position that is on axis? Neuromuscular then is the ability for the nervous system in the brain to send a message down to the muscle for it to fire. That's initiation. So there's 3 pieces of neuromuscular: initiation, strength, and endurance. So the brain says, I'd like you to fire. The muscle says, I agree. It fires. Then once it's initiated or has been turned on, does it have enough strength then for the task of toilet to wheelchair? Or does it have enough strength and endurance for, okay, maybe it turns on, and maybe it has enough strength for that first part, but does it get all the way over, does the muscle have the ability to swing 90 degrees and do that motion? Then the motor control piece of this is the ability for the individual to automatically, and if you're writing notes, put in that little word, automatic is really important, to automatically plan and execute a movement. Because the motor control piece of this is taking a sound mechanical system with a sound neuromuscular system and then using it automatically. And the automatic piece is really key because as we start to very collegially and pleasantly banter back and forth, one of the big problems that a functional manual therapist would have with the MSI approach is that MSI is all volitional. All right, I have to think about all the time squeezing my external obliques. I have to all the time think about what muscle I'm supposed to be firing. And when you're in tasks, it's very challenging to be thinking about, okay, I'm supposed to be talking to you all and demonstrating things, but are my external obliques on? They are not. Perhaps I should remember that, right? And so, when we talk about the automaticity, that's where eventually all of us want to get our patients to, right? But that would be the differentiation then between neuromuscular and motor control. Yes?
Was I not listening or not understanding where you said that over time it becomes automatic?
Exactly. I was going to interrupt my colleague here, but since you did, I will jump on that bandwagon. So from MSI motor control, we're looking at a lot of volitional contraction, building up muscle so you increase stiffness. And that's a little bit different than what we're talking about here. So over time, you won't have to really think about it because you'll be in a better alignment from the proper length-tension relationship. But kind of get to it from a different point of view.
Yes, and a functional manual therapist would say, well, I'm just going to physically, mechanically place you in a new position, which will create an automatic firing pattern without you thinking about you've got to squeeze it.
And I'd probably say more, train the heck out of it to put it in the right level and get it lined up that way.
So,
2 means 2 now. Same thing.
So mechanical movement. So, again, without consulting you all, what do we mean by mechanical, right? And so there are different pieces of it. So mechanical structures are soft tissue. By that we mean the capsule of the joint, right? We mean the fascia, all those different areas that are loading. We've got our ligaments and tendons. Really important, our nerve and vascular tissues, right? Nerve, through its sheath, can get restricted. And so we talk a lot about nerve gliding, but again, from a functional manual therapy standpoint, why would you glide a nerve that you know is stuck and just keep cranking on it? You would have to go mechanically clear that before you then go treat, quote unquote, with movement. Vascular, also same thing. So the vascular system obviously is tubular, right? You've got a big heart that's tube, and then tubes all the way through your body, going out and coming back in, with the purpose of oxygen exchange for carbon dioxide. Those physical structures also need to be moved because they are fascially connected to usually the nerve bundle, right? As everything goes through your vein, artery, and nerve. So as you have a mechanical tube going underneath, we'll say brachial plexus, underneath the under the clavicle, the brachial plexus with all of your arterial tissues there, all of that can be restricted as well. So think about those things too, not just, oh yeah, we're gonna move the muscle, or yeah, okay, I got the capsule. It's a lot more than that, especially when you're talking in the functional manual therapy approach. Joint restrictions, and again, one bone moving on another. So if you have 2 bones that are next to one another, there's a relationship where this bone can move forward, but that doesn't necessarily mean that this bone is moving backwards. That's a completely different movement, yes? Now, it's all relative, but if in space, on axis means that both of these need to be next to one another, and I've got too much motion on one side, that doesn't necessarily mean that everything now just needs to shift back like so. Because then I'm still in a dysfunctional relationship to one another despite my change in space physically. Make sense? So when we're talking about joint restrictions and joint mobility, we're really looking at one bone off of another within its physical space. So then the passive ability to attain an on-axis position for any joint. So if we think about, we'll just talk about the hip for right now. So the hip socket, it's this great acetabulum, and you've got the labrum to help out, make it a little bit deeper and give it a little bit of cushioning. And so if you have a hip that is off axis from a joint restriction, say, or muscle that is restricted, I wouldn't call it stiff in the functional manual therapy world. I would call it that it's restricted because it has a knot in it. I wouldn't expect that that hip joint is able to passively get into its center position, up, down, forward, backwards, out, in, and rotation, all those different. So I would like to, from a mechanical standpoint, clear everything before I then start teaching muscles or joints how to move.
From an MSI point of view, we probably train the muscles that are weak to pull it back. So it's the same issue, the anterior glide medial rotation syndrome that's very common in hip pain, but from MSI we probably do a lot more training of the glutes or trying to lengthen the tight psoas TFL, where from a manual therapy point of view, you push it back before you start exercise.
So then, purposely using the same slides to say, hey, how would a different set of practitioners look at this? So we've got, our hip musculature, and I'm just going to take piriformis here. Love that muscle, right? It does get a really bad rap, though. It has neighbors. Let's just remember, it has a lot of neighbors.
Raucous neighbors too.
Yes,
Lazy
raucous neighbors, I will say. Yes, very nice gluteus. But let's look at this part here. So if this muscle has a restriction, let's say in the muscle belly, right? And we're saying that we want to increase its ability to contract. MSI would say, well, let's get it to move. Or let's get it to move by, on the opposite side, activating a muscle, right? Which will then reciprocally inhibit the piriformis, which is a neurophysiological principle and does happen. But from a functional manual therapy standpoint, I would say in my experience, and what they would say with research, is that the actual knot that's in that tissue is not going to unknot all by itself. The crosslinks that are there, they're fibrous, they have changed the actual tissues and need to then relearn how to lay appropriately and in parallel, and that is going to be what allows us to either have a lengthen or, even more importantly, how to shorten on one another. Because we talk a lot about lengthening muscles that are too tight, but do we ever talk about how do we get that muscle to contract and be able to fold on itself or gather on itself? So if you think about just the elbow for a moment with this example. So if I can't bend my elbow, most of us would say it's either it's a weakness, right, where I can't activate my bicep, or triceps are too tight, right? Triceps are too tight and it won't lengthen. But think about this. If the bicep doesn't fold on itself and shorten itself mechanically, then it doesn't matter what the length of my tricep is. I can't get it to close. Much like if I were to take a water bottle or a softball and put it here, there's only so much I'm going to be able to move my arm, right? And so it's that idea. If I can remove the mechanical restriction, then I can get the muscle to activate it, regardless of what's happening on the opposite side of the joint. All right. So, lumbosacral spine. Looking at these lovely ligaments going along here. A functional manual therapist, go ahead.
Do you guys, we're doing a lot of talking about the musculature and the dysfunctions, speaking more along the lines of like a cause and effect relationship, do you guys ever take into account as this dysfunction may be coming from another area, as in, yes, the piriformis might be tight, causing constriction on the sciatic nerve, but do you guys ever take into consideration in either you guys' I guess experience, being that they're different, treating more outside of the location of dysfunction?
We
as
get
in the nervous
criticized by patients to say, why are you treating my tailbone? It's my shoulder. Why are you looking at my ankle? My hip is killing me. So all day, every day, yes.
Or vice versa.
And vice versa.
Ankle drove.
Yeah, the ankle will,
Yeah.
right.
So absolutely, we do, and that's one of our little stretchy points with the society around us. So, if we find a dysfunction elsewhere, either from a motor control or manual therapy point, we just have to go and educate whoever sending them the prescription or whatever to say, hey, we're going to treat the whole body here. We're just not going to treat one little segment or piriformis syndrome when they have weakness of the thoracic spine or ankle issues that are creating too much rotation, causing the piriformis to become irritated or stiff or
Another perfect example is a patient who's had shoulder surgery, has gone for 12 cortisone shots, they've been to 15 different physical therapy places, they love their chiropractor, but they're apparently not working anymore, so they're worried about breaking off that familial relationship. They've been to acupuncture, you know, all of those other practitioners, and then more likely than not, that's because people have zoned in on this one part of, okay, well, I guess the rotator cuff isn't firing right. Probably the rotator cuff is not firing right if someone is having that much treatment. But that doesn't necessarily mean that that's the only area that one needs to treat. One needs to then look at what's the alignment. Can the tissues get on axis? Can the humerus get on axis? Can the scapula get on axis? What about the rib cage? Each one of those ribs, more likely than not, that patient has a rib cage dysfunction and has one rib that just probably needs to actually rotate and be able to do a PA glide, settle into the thoracic cage better, and then the scapula now has a place to set and learn how to move. So, again, we don't need to go there, but make sense? Does that answer your question? Okay.
We just use a little different approaches to get them to move, but,
Yes.
but the idea is getting efficient alignment throughout the system. It affects that upper quarter, lower quarter dysfunction.
And then also looking
Great question.
from a joint perspective, if the sacrum is off axis, or let's say it doesn't nutate well, so the sacral base does not move forward, that means that this area, which is going to be the attachment here of the piriformis, is going to be inherently at a different position, right? Which of course will change the length-tension relationship, right? It just has to.
We're using the same lingo too, but it's kind of interesting that we're both talking about length tension relationship. We just talk about
Just differently.
pushing it or pulling it. So.
And so then same thing here, you know, just looking at all the fascia, ligamentous, if you have, so sacrotuberous, let's say you have a dysfunction here, is that going to affect the hip? Well, people would say, of course not, it's not gonna affect the hip. But how can that not affect the hip socket? Because if you look at this bone, which is the innominate, how many different connections does it have? The left innominate has how many different connections to other bones? 3, right? It's connected at pubic symphysis to the other bone, other innominate. It's connected at the hip socket, and it's connected at the SI joint. So any dysfunction that you have where this ligament is changing the orientation of this bone in space will obviously affect what's happening at the femoral, the acetabulum, right? Where the femur then accesses that bone, right? So looking at the joint mechanics then would be very important, and making sure that that innominate is in its ideal position. Okay, so underlying evidence for does manual therapy work or not, right? For those of us who would consider ourselves manual therapists, it's a pretty big deal, right? Insurance companies are saying, I don't know if it really does. Massage therapists are doing manual therapy too, so don't worry about it. We're just gonna slap manual therapy people who have lots and lots of training with people who are massage therapists, and we're just gonna cut that reimbursement by what, 40% is what Blue Cross did at the beginning of, end of last year. And there's such backlash that they changed that. So that's a different issue. So they wrong talk. Okay, so McDonald et al., 2006, took 7 cases, and every single one of them had a positive response to manual therapy. Was it because they're touchy-feely people and they love to be touched? Maybe. Was it because they mechanically changed something? Possibly. Was it because the touching of them actually changed their movement patterns? Maybe. We don't really know, but we do know that manual therapy was the intervention, and they had good responses from that. Hoeksma in 2004, talking about manual therapy only versus exercise only for patients with hip OA. And we had an 81% success rate with manual therapy and 50% with exercise. Now, is it because they had therapists like Bob who are doing clams the wrong way, doing bad clams? Maybe.
Or weren't giving clams at all because they're just so awful.
That's right. Is it because they just chose the wrong exercises? That's possible. Or again, maybe they just had a bunch of touchy-feely people who really love manual therapy and connected so well with their therapist. It could have been that too. Or maybe they just had much better manual therapists than they did exercise therapists. That's all possible too. However, from all these different people, 81% success rate, that's not bad. No, I broke it. Oh, maybe we did. What did you do? Want to go down? Can you make it happen? Oh, broke it.
on the
What did
feeling
you do?
yesterday, we did, I hit one and then one again, I hope that works for them.
One and one again.
Oh, but ours turned off.
I'm gonna take it out here and see
Okay.
if it does it by itself.
Okay, so
Can't,
just.
can't the Macs aren't supposed to freeze? Give us a second. Go back on.
Woo! Good job. Okay.
Reset.
Thank you. So research, there was Greg Crawford, did a systematic review on a number of different articles, and again found that manual therapy, which didn't just include soft tissue mobilization, it was thrust as well, so everything from just soft tissue mobilization, very, very gentle, all the way through grade 5 thrust, was much more effective than just doing exercises alone. So with the IPA, being that they have 15 different courses, I only picked out a couple of different key components that were really important to demonstrate within this time frame. So we're going to be looking today at the coccyx, sacrum, innominate, and hip, and looking at how does dysfunction at one of those bones affect the low back and or hip, and we'll actually do it with a real patient. So the joint plan mechanical overview. This is what I'm actually going to check on our subject. We're going to look at the coccyx. Is it rotating well or not? So we're not looking at positional, but we're looking at actual joint movement. So does the coccyx rotate well off the sacrum? Is it in a flex or extended position, and does it have spring to it? Side note, the sacrococcygeal junction is a synovial joint. So if you don't think it moves, check out some more research. There's a lot of research to support it. It's a synovial joint. It's gotta move, okay? So sacrum, we're gonna look at nutation and counter-nutation. And really looking at, the sacrum is so enormous, we're going to look at it very specifically within that motion, not just sagittal plane, because no one has just sagittal plane motion dysfunction or frontal planar transfer, right? It's always coupled with something else.
And from a movement versus mechanical, you're looking more force closure versus form closure. April will probably talking more about form, actually putting the joint in the socket. I'll be more concerned with force, meaning the latissimus and glutes are doing what they're supposed to do to stabilize that area. Now in MSI, she's not big on the SI joint moving too much.
As in, like, it doesn't move. She doesn't believe it. She really doesn't believe that the SI joint moves. Okay.
But you know,
I'm
you
sure it will.
could get the form closure from forceful movements of the hip.
So then the hip, we're going to look at the anterior to posterior, which is what AP is. So AP glide, as well as an inferior glide of the socket. So taking the femur like so, and because there's space here, seeing how does it glide inferiorly. Really important for patients with, we'll get to that later. So looking at Van Dillen's study about patients who have back pain, of course they have hip dysfunction, right? And that's why we want to look at that. And then for the innominate, we want to look at internal and external rotation, by which most people would say in flare and out flare, but I'm not actually going to do anything with the ASIS, because what I care about today in this presentation is not static position. I care about the relationship of bone to bone. So I'm going to look at the PSIS, and if the right innominate is in a quote-unquote out flare, which I would term, or a functional manual therapist would term, external rotation, what does the PSIS do in relationship to the sacrum? And it moves medial and anterior. Okay? So external rotation is that. Internal rotation or in flare would be just the opposite, a gapping, if you will, of the PSIS off of the sacrum. And so if you're going to turn like so, my innominate off of the sacrum would need to be able to do an internal rotation so that I can walk up. Okay? All right. And then flexion and extension. In the Institute of Physical Art, flexion is posterior rotation, like so, and extension is anterior rotation in the sagittal plane. And again, we're not looking at it overall, I'm looking at it according to the sacrum, right? Because if I'm just looking at the ASIS, there is no bone to compare it to right next to it. Okay, remember, we're looking at one bone in comparison to another. All right. And then AP glide of the sacrum. And I do mean AP, like we're going to go through the abdomen. Okay, and I'm not going to do an indirect PA glide to L4 to see what L5 does. I'm going to do anterior to posterior and actually press on the anterior body that way. All right, and then joint arthropneumatics, how one bone moves on the other. being that we've already talked about this, we don't have to go too much through this, but you know, how does the whole bone behave? And if you're looking at, say, like L5, it's got enormous connections, right? We've got the facets on top, we've got the facets on the bottom, so that's 4. We've got the body on top, body on bottom, that's 6. It's got 6 different points of connection that we need to be looking at, and how one of those will affect the other's ability to participate in the movement segment above and movement segment below, right and left. So one joint does not work independently from the other points of contact. So again, using the same study on purpose, individuals with low back pain demonstrate different movement patterns, and those different movement patterns, kind of the chicken or the egg like you're talking about, right? Which is, do they have a bad movement pattern to begin with, and therefore their joint got worse? Or do they have a terrible joint to begin with, and therefore their muscles responded? I used to spend a lot of time thinking about that, and still sometimes it's important to me. Other times, it doesn't really matter to me, because I know that I can treat both, and if one way doesn't work, then I simply turn around and treat it the other way. So, chicken or the egg, really, since you haven't followed your patients around, how do you know? You just treat what presents to you at that time. So the physical examination then, again, there's a ton of different tests that we can use as a pre or a post test or a comparable sign. I'm going to give myself these options here of functional tests, which is lumbar protective mechanism. It's a great test that Greg and Vicki Johnson came up with from runners. We can talk more about that when we do it. An elbow flexion test to see how does my upper body take weight through into my feet, because this is something that we do all day long. It's a very functional test to see how does my body respond. Active range of motion testing, we're going to look at hip, seated and standing. Lumbar assessment, same thing, range of motion, and then looking at manual muscle tests and supine and sear. So basically, from a functional manual therapy standpoint, I want to get my joint restrictions moving, and I made up this one, so I can unobstructively create movement. There was no spell correct on it. They gave me some words. I'm like, no, that's not what I want. I want unobstructed creation of movement, right? So the biggest thing with the Institute of Physical Art is I want to go in the direction of maximum resistance. Yes, the body follows the path of least resistance, so if I'm going to affect change, I've got to get it off of that least resistance and into where it doesn't want to go, right? So that's where I'm going to go a very direct approach with this. Follow the path of resistance. Okay, where does it not move? I help it move because that's what it needs more of. And then train the body in the range of motion. So, last little point of comparison, I believe, which is psoas and anterior spine. So from a functional manual therapy standpoint, we would say, okay, here's your psoas. If it's really, really restricted, I'm going to use a mechanical force to create a mechanical change to allow it to either lengthen or fold.
In an MSI approach, you're looking at an extension syndrome that's probably going to have not enough length to be very stiff, too stiff, and then in a flexion syndrome, not stiff enough, so you're looking at changing the relative stiffness depending if they have trouble flexing or extending. More from an exercise point of view, activity point of view, daily habit point of view, rather than a manual manipulative point of view.
All right, then for treatment, so we're going to have our pre-test, we're finding a comparable sign, we're going to go and treat all of those different things, which literally in the clinic can take less than 8 minutes, or here it'll take us probably close to an hour. And then we do our post-test, and we hope to have a change. It's going to be a little embarrassing in front of all of you if it's not. So manual therapy conclusion, basically we're going after the restrictions, we're going to go direct treatment, being specific, and then retraining that movement. Bob, you want to take that
Yeah.
slide?
So, at the end of this, I'm going to be representing one camp, April the other. In actuality, we belong to both, which is kind of interesting. We have cards in both karate dojos, as I said before. So movement is to motor control, as the wind is a boat is to a boat as wind is to a sail. You need movement to get that boat moving. So it pushes the vessel into the direction. The boat is off course, the wind will continue to move it off course. Manual therapy is to a boat rudder, the thing that steers it, is to a vessel as, manual therapy is to a boat as a rudder is to the vessel, which means it could turn the boat back onto course, but it can't bring it back to port. So the combination of both manual therapy and motor control really gets that boat in the right direction and back to course. So at the end of this, you'll see how the marriage of both manual therapy and motor control, or motor control and manual therapy, gets the patient back to course, back to the course.
One moment. So, my other very grand, really grand idea on this is, all of us in manual therapy, in physical therapy, have a horror story about what the next clinic overdid to your patient now that you're treating to fix them, right? We've got lots of stories. I'm sure some of our patients at Body Gears have gone out and gone and seen you, right? And you're like, oh my gosh, they don't know what they're doing there. Or we're like, oh my gosh, like Mickey, I mean, you haven't treated for a while, so it hasn't happened in a while, but